So shall we start?
So just a minute. We are doing. So you can start now.
Good evening, friends. Hope you all are doing well. And at the outset, I like to thank IJCP for giving me opportunity to talk on a very important topic. Although hypoglycemia looks very simple or easy to understand, and we all know every one of our diabetic patient has some or the other time experienced hypoglycemia in his or her life, whether they are on insulin or oral hypoglycemic agents. And with the goals now getting stricter for a better and tighter control of blood sugar levels below 7 or 6.5% of HbA1c, the incidence of hypoglycemias are increasing. So today I would be talking on briefly about the latest about the pathophysiology, the treatment and prevention of the hypoglycemia in our patients. Hypoglycemia, we all know, is defined as a condition where plasma glucose concentration is low, which may expose patients to various forms of harmful results. This is quite common in patients with type 1 diabetes. And according to a latest study, the annual incidence of severe hypoglycemia ranges between 3.3 to 13.5%, which is quite alarming. But in type 2 diabetic patients, hypoglycemia are quite lesser nowadays because of the latest drugs available, which do not directly cause insulin secretion, like DPP-4 inhibitors, metformin, GLP-1 receptor analogs, thiazolidinediones, the SGLT2 inhibitors. They are all associated with lower risk of hypoglycemias, but insulin or insulin secretagogues, they may cause higher risk of severe hypoglycemia in type 2 diabetic patients. And historically, we'll see how in UKPDS and DCCT trials, it was shown that a good sugar control prevents micro and macrovascular complications, but that had led to increased risk of hypoglycemias. UKPDS, the HbA1c goal was 7% in the intensive treatment arm, but then the yearly incidence of severe hypoglycemia in those type 2 diabetic patients ranged to 0.7 to 1.8%. DCCT, at least one episode of severe hypoglycemia during each follow-up was experienced in about 65% of type 1 diabetic patients in intensive arm. In ACCORD advanced VADT trials, significant increase in hypoglycemic episodes were observed in intensive compared to the standard treatment groups. So we have studies showing us good sugar control has benefit in micro and macrovascular complication, but then in both type 1 and type 2, there are increased chances of hypoglycemias. And this is again same. A lot of observational studies, they say that there is a significant reduction in incidence of severe hypoglycemia, especially in type 2 diabetic patients, with new drugs like I have told you earlier about DPP4, SGLT2, metformin, etc. In last 20 years, the incidence of hypos have come down. But then we should know that the threshold for the appearance of hypoglycemic symptom is different in different patients also. So it's not the laboratory values or the cutoff, but then it depends on the patient's age, the comorbidities, the concomitant use of insulin secretagogues or insulin. And this threshold drops due to recurrent episodes of hypoglycemias in patients who have uncontrolled diabetes. So when we talk about the classification, the levels of hypoglycemias, we have level 1, 2, 3. Level 1 is defined as plasma glucose less than 70 mg per deciliter, but more than 54. Here, 70 milligram per deciliter glucose constitutes the threshold concentration, below which the neuroendocrine response to hypoglycemia appears without diabetes. Many patients with diabetes suffer from this impaired defense mechanism, or there is lack of hypoglycemia awareness. Therefore, less than 70 is defined as a clinically significant in diabetes and require intervention, irrespective of the patient's symptoms. So don't think that patient is not complaining. We should treat it. Level 2 defined a glucose concentration below 54, which requires immediate intervention to correct the hypoglycemias. Level 3 is a serious event characterized by a change in the mental status of patient and impairment in the physical ability to function that requires intervention by another person to correct the glucose concentration. So these are the levels of hypoglycemia. Then the symptoms, we have typical autonomic and neuroglycopenic symptoms. And again, I would say these vary among patients according to the age, duration of diabetes, and the comorbidities also. Like children may demonstrate more of emotional and behavioral changes, along with classical autonomic and neuroglycopenic symptoms. We may get kids who are just irritated, who are not performing well in classrooms. These may be the only symptoms in smaller children. We have autonomic symptoms like anxiety, tremor, palpitations, diaphoresis, paresthesia, and sensation of hunger. Neuroglycopenic symptoms include lack of concentration, headache, blurred vision, dizziness, confusion, convulsion, speech disturbances, restlessness, and loss of consciousness. And this is basically due to glucose deprivation and neurons. And the threshold for this symptom is 54 mg per deciliter. But unlike autonomic symptoms, the onset of neuroglycopenic symptoms are not affected by counter-regulatory hormone failure or previous episodes of hypoglycemias. What are the risk factors? Conditions which cause therapeutic hyperinsulinemia or failure of this defense mechanism, the counter-regulatory hormones, which can be seen in patients who are treated with insulin or insulin secretagogues if they are administered in high dose and at incorrect timing related to meal. Then the lack of exogenous glucose, when a person is taking very low carbohydrate diet, or there is a prolonged fasting in diabetic patients, or there is lack of endogenic glucose, the hepatic glucose production after drinking alcohol, or there is an increased glucose consumption during or after the physical exercise. This should also be taken care. People who go for gymming and regular walks during morning, increasing insulin sensitivity due to weight loss or physical exertion, drop in insulin secretions under conditions such as renal failure, hepatic failure, and hypothyroidism. Then, as I was talking about the counter-regulatory response to hypoglycemia. So it leads to two main responses. There is an increase in endogenous glucose production by glycogenolysis and gluconeogenesis, which takes care of the dropping blood sugar level. And then we get the behavioral changes leading to sensation of hunger and food seeking, so that the person takes food and covers up the hypoglycemia. In non-diabetic patient, what happens? There is an initial response of drop in insulin secretion. So as the glucose goes down, even the normal secretion of the insulin is reduced. And then the additional drop in glucose in normal physiology causes increased secretion of glucagon and epinephrine, also cortisol and growth hormone, although they have got less significant. So that the lower glucose concentration activates an intensive sympathoadrenal reaction, which leads to appearance of these symptoms and additional lowering of this of glucose concentration. If these counter-regulatory hormones are also not working, there is a cognitive deterioration and severe neurological effects like convulsion or loss of consciousness in patients. So these are the defense mechanisms which are often impaired in patients with diabetes and significant beta cell failure. So this is not seen in patients who have a prolonged duration of diabetes. And this rate of hypoglycemia, they increase with the duration of diabetes, which is seen rapidly in type 1 diabetic patients and slower in type 2 diabetic patients. So in type 2, it is also seen, but it is slow compared to type 1 diabetic patients. And this is very important, hypoglycemic unawareness. It is believed that there is an impaired sympathoadrenal response, which is secondary to repeated episodes of hypoglycemia. And this is very, very dangerous. That reduce the autonomic response to hypoglycemia. So when a patient is constantly having hypoglycemias so many times in a day or for a longer duration of time, this exposes the patient to vicious cycle of frequent hypoglycemias and shifts the glycemic threshold for lower plasma glucose concentration. As I said, less than 54, but then a lot of people, they don't get these autonomic symptoms also, even at 30, 40 also, which are quite close levels, which can cause cognitive failure. And this condition was first defined by Cryer as hypoglycemia associated autonomic failure, or HAAF. Here, the defense mechanism may be impaired by repeated hypoglycemias, physical exercise, and sleep also, thus contributing to development of hypoglycemia unawareness. And here, recently it was shown that recurrent hypoglycemias can develop as a result of reduced autonomic response to hypoglycemia with attenuation of autonomic warning symptoms. And this defective brain response is characterized by increased GLUT1 activity aimed at preserving brain function and altering the glucose sensing VMH mediated by elevated levels of GABA. So this is, you can see the normal response to the recurrent hypoglycemia. The increased GLUT1 activity, altered VMH sensing, and increased GABA levels, which causes diminished autonomic response to hypoglycemia. So the person gets less sweating, then there is less glucagon production, absence of the palpitation, there is reduced production of catecholamines, there is absence of tremor, so the patient doesn't feel, he or she doesn't complain, and the relatives are also unable to guess that what is happening with the patient. But then this recurrent hypoglycemia or HAF causes this diminished autonomic response to hypoglycemia. So why hypoglycemia is important in diabetes? Because it can cause both physical and psychological morbidity in our patient. Obviously, we all have seen hypoglycemia and we can know that how this is a concern and a distraction or a social shame sometimes for a lot of diabetic patients. And on the other hand, it can impair judgment, performance of simple daily activities like driving, or even the behavior of a person. Most severe cases, patients may go in convulsion and loss of consciousness. They may have transient or permanent neurological problems. DCCT addict in that follow-up of 18 years show that there was a slight reduction, maybe not significant, but there was some cognitive dysfunction with repeated hypoglycemias. And other studies, especially in diabetics, have shown, in elderlies have shown that hypoglycemia had twice the risk of developing dementia in elderlies. A lot of studies are there. You can see meta-analysis of more than 9 lakh patients, twofold increase in risk of cardiovascular morbidity, patients with type 2 with severe hypoglycemias, may be due to the sympathoadrenal response and marks increased levels of catecholamines, which cause direct effect on myocardium and vascular system, along with platelet aggregation and activation. In type 1 also, it increases mortality 4 to 10% in type 1 diabetic patients. Although severe sustained hypoglycemias may cause brain death, with most sudden deaths are related to cardiac arrhythmias due to enhanced sympathoadrenal reaction causing QT prolongation. Type 1, type 2, various studies across the world have shown 1.5 to 6-fold increase in risk of cardiovascular events and mortality among patients who experience severe hypoglycemia. And this is the mechanism by which hypoglycemia may affect cardiovascular events, which I've already explained in brief. Hypoglycemia in pregnancy is quite challenging because we usually keep the blood sugar levels quite low while treating GDM during pregnancy, and a marked hypoglycemia increases up to 5-fold hypoglycemia in the first trimester in type 1 diabetes. Fetus is usually not in danger, but mothers can have problems, especially of injury. Hospitalization, we all know, a lot of our patients with diabetes, they have recurrent hypoglycemias because of comorbidities, the variability in feeding, the dosing. So obviously for majority of critical and non-critical ill patients during hospitalization, we should keep a target of 140 to 180 mg per deciliter. Now coming to treatment of hypoglycemia. Most important is self-monitoring. We should all explain to our patients and their relatives the self-monitoring. And then whenever required, give them 20 grams of glucose or a long-acting carbohydrate. And I will show you a protocol, the latest protocol, which came from Joint British Diabetes Society in 2021. These are the guidelines. I think difficult to read, but here we can see adults who are conscious, oriented, and able to swallow. If they are on insulin pump or IV insulin, stop it. Give them 15 to 20 grams of rapid acting carbohydrate, like 15 to 20 grams of chewable glucose tablet, or a 200 ml of orange juice, or 3 to 4 heaped teaspoons of sugar dissolved in water. And then check every 10 to 15 minutes. If the blood sugar is still less than 70, repeat the previous steps. And if the blood sugar levels remains less than 90 even after 30 to 45 minutes or 3 cycles of the above treatment, give 200 ml of 10% glucose over 15 minutes, or administer 1 mg of glucagon IM. Once it goes above 70, then patient can be advised to take a normal routine meal. Then the second scenario, patients who are conscious but they are confused. They are unable to cooperate but are able to swallow. Again, stop the insulin pump or IV infusion. Give them something like 15 grams of glucose, or give 1 mg of glucagon. Repeat sugars after 15 minutes. If it is less than 70, we should start a IV. And here we should remember, glucagon should be given only once. There is no benefit if the sugar level doesn't come after a single shot of glucagon. Another scenario, patients who are unconscious or having seizures, we have to first go for airway breathing, circulation, the consciousness, blood sugar level, body temperature. Start a IV insulin, 100 ml of 20% glucose, or 200 ml of 10% glucose over 50. If no immediate IV access is available, give 1 shot of 1 mg glucagon IM. Still, if it is the IV administration, the access is not available, we should not repeat the glucagon injection. Get IV access, repeat blood sugar levels after every 10 minutes, and keep on giving IV glucose till the blood sugar levels are above 70 or the patient regains the consciousness, able to take glucose or take a food. So this is the flow chart. Here we have already discussed. I won't go in detail. Now coming to the prevention of hypoglycemias. These approaches are very, very important. When we go for a strict control in most of our diabetic patients, try to avoid giving insulin or insulin secretagogues in higher doses to patients who are at risk of getting hypoglycemias, like patients who are quite elderly, whose diet is not fixed, or if they have any other comorbidities like chronic liver disease, renal disease, or uncontrolled hypothyroidism. So patient education is very important. We have to counsel them for appropriate dietary regimes, exercise regime, glucose monitoring regularly, medication adjustment from time to time, and obviously a close clinical supervision. Patient education. So we have to tell that whenever they skip a meal or prolonged fasting, physical exertion, alcohol consumption, they should watch for hypoglycemias, and we should educate the family members also and people in the environment of patients that they should watch for these symptoms. And in these high-risk individuals, a glucagon injection should be kept for emergency. Dietary intervention. Yes, we should emphasize, especially people who are taking insulin, to take food at proper time. And if they are taking meals also, we should explain to them that this drug will start affecting after this much of time. So in between also, if they want to have meals, they can have a small frequent meals. And we should make a personalized regular meal plan according to the medicines we are giving to our patients. Recommendations on physical exercise. They should be monitoring blood glucose levels before and after a physical activity, and small meals should be eaten prior to physical exercise if they know that their blood sugar levels will drop after the exercise. And they are recommended to keep with them rapid acting carbohydrates during physical activity, and then consult a doctor to adjust the insulin dose or insulin secretable dose according to the exercise schedule or the SM or the self-monitoring blood glucose levels. Glucose monitoring, again, I would re-emphasize on self-monitoring of blood glucose, SMBG, and continuous glucose monitoring. The integral part of any diabetes management to prevent hypoglycemias, especially in intensive insulin regimes like multiple daily injections or pumps to check sugars before meal and occasionally postprandially also, before sleep, during exercise. So all these should be done regularly. Then the medication adjustment. Yes, this is very important. Patient should not keep on taking extra carbohydrates with the fear of hypoglycemias, because that may cause glycemic variability, lots of ups and downs, increase in their weight also. Better is to consult a doctor, adjust their medication, go for drugs which cause less hypoglycemias like metformin, DPP-4 inhibitors, GLP-1 receptor analog, SGLT2 inhibitors, and pioglitazone. And if we want to use insulin, we can shift them to long-acting basal insulin analogs. And now we have rapid-acting insulin analogs also, which has led to significant reduction in severe hypoglycemias. And we have for type 2 diabetic patients now, combination of basal insulin and GLP-1 analog in a single syringe, which shows significant improvement in diabetes with weight loss and very less risk of hypoglycemias. Then a few words about artificial pancreas, which is a closed loop system combining the real-time CGM and continuous subcutaneous insulin infusion, which gives, according to the glucose algorithm, the insulin delivery is there. And the use of this artificial pancreas can reduce burden on patients by automatically adjusting the delivery of insulin based on the sensor glucose levels. And then a single hormone or insulin only or dual hormone, as I said, insulin and glucagon systems have also been developed. And in recent systemic review and analysis, it was shown that artificial pancreas technology constitutes an effective and safe treatment for type 1 diabetic patients to keep the diabetes well under control and reduce time in hypoglycemia. Pancreatic islet transplantation might be a great promise for patients with type 1 diabetes. And a significant progress has been made to improve islet function and clinical outcomes after transplantation. There were good sugar control, reduced episodes of hypoglycemias, and improved hypoglycemia awareness in these type 1 diabetic patients. So, to conclude, hypoglycemia in diabetes is associated with increased morbidity and constitutes a barrier to glycemic control. Great efforts must be invested in patient education on hypoglycemia prevention and its management by themselves and by their family members. Appropriate dietary and exercise regime should be made tailor-made for each patient. Adjustment of the treatment regime with better available recent medications can be done, and glucose monitoring should be implemented as and when required. Thank you. So I think we have few questions here. We'll see. Why is the timing of onset of symptoms related to meal ingestion significant in evaluation of hypoglycemia? Yes, see, as I have already talked about this thing, that the symptoms may come or may not come depending on the individual's age, duration of diabetes, and comorbidities. Why is rapid diagnosis and treatment of hypoglycemia necessary? As I have shown you in my lecture, that how if we don't treat the hypoglycemia immediately, especially below 54 mg per deciliter, it may cause cardiac arrhythmias, sudden cardiac death, convulsion, coma, transient or permanent neurological deficits also. And what is the effect of non-severe hypoglycemias on diabetes management? Yes, a lot of our patients, they may not have all these problems like what I told just now, but if they are not that severe also hypoglycemia, it may affect their quality of life. They may look confused, there is lack of concentration, they are not able to perform properly. So if this happens regularly in those patients, definitely there is a severe drop in the quality of life of these patients. Maybe it may not increase the mortality, but then it will definitely affect the quality of life. Which medication in the drug anti-neoplastic agents are used for the treatment of hypoglycemia? Yes, we can use drug like diazoxide is there. We can use this drug in patients who have recurrent hypoglycemia, but this is only for a shorter duration of time. But yes, we usually give otherwise IV glucose or 1 mg of glucagon IM only once. But the main thing is take care of the comorbidities, frequent monitoring of the blood sugar levels, and giving IV glucose to those patients who are not able to take the food or who are not conscious. Okay. So thank you for your interest, and thank you IJCP for